We'll finish up this chapter and then go into blood vessels today. Remember last time we were talking about the regulation of the heart rate. We have the intrinsic regulation of the heart rate, that's the nodal system, and now we're going on to the extrinsic regulation of the heart rate, so other factors can actually affect your heart rate. And the autonomic nervous system is going to play a big role for our extrinsic regulation of the heart. And the sympathetic nervous system will actually have receptors there at the SA node and will release norepinephrine at the SA node, which will cause more rapid depolarizations or pacemaker potentials, and we'll get a more rapid heart rate. And it does this by increasing sodium leakage. So the more sodium coming in, the more depolarization that you actually have. Parasympathetic nervous system, it's actually the neurotransmitter is going to be acetylcholine. It's going to be dumped on the SA node. That actually causes potassium gates to open up. That causes hyperpolarization. So as you try to depolarize something that's hyperpolarized, it takes you longer to actually depolarize it, and that slows down the heart rate. Vagal tone is what we refer to with this parasympathetic dominance that we actually have. Remember, the vagus nerve is our cranial nerve 10, and it's called the vagus nerve because it's a vagabond. It wanders, and it creates various plexes in the thorax as well as in the abdominal area. We have pulmonary plexus as well as an aortic plexus. So the vagus nerve is actually there, forms a plexus, and has the predominant output to the SA node, telling it, slow down, 100 beats a minute is not what we need for rest digest mode. So that's called vagal tone. And it keeps our heart rate around 70 to 80 beats per minute, depending upon the individual. Yes?
So when someone's heart rate is too high, and then the nurse says, hold your breath and try to bear down, to try to get the vagal down, they're trying to tell their heart to start beating slower, is that what they're trying to get them to do?
Yes, when they do those Valsalva maneuvers, they're trying to actually stimulate vagal tone now, or increase the vagal tone, which will actually decrease the heart rate. Absolutely, yes. So correct. We also have some receptors that are responsible for giving additional information about your overall well-being to the SA node, and therefore dictate the rate of the SA node. And the receptors that we are interested in are baroreceptors or pressoreceptors. Baro, pressure, same thing. And these receptors are in the areas that actually have their names associated with them, and they will give the brain information about the pressure that's inside these specific areas, and will therefore regulate the heart rate that the heart is going to undergo, because heart rate is going to impact cardiac output, correct? And let's talk about the first one, and then we'll talk a little bit more about how these pressure receptors actually work. The carotid sinus is an area that is at what I would call the end of the common carotid, because the common carotid comes up to the jawline area and then bifurcates or branches into the external carotid and the internal carotid. The external carotid supplies blood to the exterior of the skull, and the internal carotid supplies blood to the interior of the skull. And the carotid sinus is right there at that bifurcation. It's a little bit more going towards the internal carotid, because your brain is like a picky eater. It only wants certain things. In other words, it only wants a very specific amount of blood flow, and it wants that blood flow at almost all times. Rest, digest, or even activity related. It says, I demand you feed me glucose at a constant rate so that I can have my normal neural discharge. So the brain is real finicky, and it wants, I'll tell you the number right now, and we'll go into it later on in the next chapter, around 750 cc's of blood flow per minute. So it says, this is what I want, don't give me more, don't give me less. So if we are experiencing an increased blood flow to the brain at the carotid sinus, this is going to cause an increased stretch, correct? And if we increase the stretch and therefore increase the flow, and the brain will tell the heart to do what? The heart doesn't constrict. The heart beats. the heart to slow down, because flow is definitely related to heart rate, correct? So the thing that's easiest to actually modulate is heart rate. You can always modulate blood pressure, but it's easier and quicker to modulate heart rate. So too much flow to the brain says, whoa, put on the brakes, slow down the heart rate. So increased blood flow will cause a direct command from the brain to our SA node to decrease the heart rate. So now if we have decreased blood flow, it should be pretty easy to figure out what we're going to actually have now transmitted to the heart to do. Increase our heart rate. So this is what's real important. Blood flow to the brain is relatively constant. And so too much is bad, put on the brakes. Too little, pick it up. Pick up the pace or pick up the heart rate. So that's how the carotid sinus works. The aortic bodies are similar to the carotid sinus bodies. So carotid sinus, let's add that to that. Carotid sinus bodies. It just tells you where they're located, correct? They're located in the aortic arch. Now, this is kind of like a backup system, wouldn't it be to you guys? This would be a bit of a backup system to blood leaving the heart. And indeed, this is a very important system that the two are supposed to work together, supposed to reaffirm one another, so to speak. But as we age, neurologically, we also deteriorate a little bit. Yes? You know, your reflexes aren't as fast as they used to be when you were a teenager. That's actually when your reflexes are the fastest, is when you're teenagers. And as you get older, other things start to slow down and don't work so well. You've noticed that. Word recall, for example, things along that line. We have those moments. So what's important about this is, why do we need to actually have these reflexes here to regulate our heart rate? Because of blood flow to the brain under ordinary circumstances, because I'm telling you, the brain is specific about how much blood it wants flowing to it. So right now, standing up, my heart rate's a certain level, correct? What happened to my heart rate if I laid down? It would slow down, because why? Because suddenly my pump was pumping out a certain volume against gravity to my head, yes? Well, if we still keep pumping out, just like I was standing up, what will happen to my blood flow to my brain? It would be too high, it would increase. And so that's part of the baroreceptor response. That's why your blood pressure goes up and down, or not blood pressure, but heart rate and blood pressure too. But heart rate goes up and down when you go from standing to sitting to laying down, and then vice versa. Now, as we get older, what I was alluding to is that there is a medical condition that is related to a bit of a failure of our carotid sinus, the bodies in the carotid sinus. And it actually has a specific name, and it's called orthostatic hypotension. Has anybody ever heard of that? Yeah, it's where old people, when they get up out of bed, need to do it, what, fast or slow? Slow. Because if they get up too fast, their blood pressure and their heart rate, suddenly our heart rate bottoms out, because it goes, whoa, I'm not getting enough blood flow, and I will make you lay down, because I know I will get enough blood flow when you lay down again. So this mechanism is important for older people, because they have a little bit of the failure of the system to work properly, and that's where orthostatic hypotension comes about. Yes?
So if someone who's younger has orthostatic hypotension, is that a failure of their carotid sinus or their receptors?
If somebody that's younger has a problem with orthostatic hypotension, it is often related to intravascular volume. Because when you lay down and you're a little on the dry side, it's not a big deal, is it? But when you stand up and you're a little bit on the dry side, what do you guys know about volume going to the brain then? It's going to be same or less. It's going to be less. And so it's all related to some of those actually volume-related phenomena too. So younger people, it's more likely volume of the intravascular system, but it could also be a neurological issue related to the carotid sinus and the carotid bodies and the carotid sinus. But you notice that they have a backup system, just like the heart has a backup system for heart rate. We also have a backup system for pressure above the heart, because the aorta is above the heart, and so is the carotid sinus. But the carotid sinus is closest to the brain and will be a more powerful regulator of blood flow to the brain. Let's look at the last one here. Last baroreceptor is called the atrial reflex, and it was obviously named after a guy named Bainbridge. This is a sympathetic reflex, so that's a big clue as to what we would expect the heart rate to do right off the bat here when this reflex is initiated, yes? Based upon that, just for me telling you it's a sympathetic reflex, that tells you heart rate should go up. Okay, the receptors for the atrial reflex are in the atria, and that's why it's called atrial reflex over Bainbridge. We prefer that. And the veins are emptying into the atria, and they're bringing venous return to the atria because they're receiving chambers. Well, what happens if you bring too much blood to our atria, our receiving chambers? Will you not cause a distension of them and increase pressure inside them? And see, they don't like that either. They don't like to be stretched. They like to just fill normally and not have to undergo this unusual extra volume. Because if they're full of extra volume, the body thinks the whole body's full of extra volume, and we need to get that extra volume that's now accumulating in the heart out. And so what will happen when the atrial reflex is initiated, it's telling the brain that the heart has too much congestion. And just like a congested nose, you try to blow it, right? You try to get the extra fluid out, and that's what the atrial reflex is designed to do. That's why you should relate it to a sympathetic reflex. Their distension will directly activate the SA node to increase the heart rate. And this is done to relieve congestion of the heart. Chemical controls, we're just going to talk about two of the chemical regulators of our heart rate, hormones and ions. Hormones, epinephrine and norepinephrine. And remember, when we see them together, we typically think of adrenaline, and you know what happens to your heart rate when adrenaline's in your system, correct? The heart is beating faster and more forcefully. So that's an example of a hormone because it's dumped into the bloodstream when it's the form of adrenaline, correct? Okay. Then thyroid hormone. Thyroid hormone, remember, is your major metabolic hormone. And if your cells are more metabolically active, you need more oxygen. And if you need more oxygen, you need more blood flow and blood and all that stuff. So the heart rate will actually elevate in response to the body's demands for the need for more oxygen and nutrients. So that's the hormonal aspect of this. Ions. Well, we have to have proper ionic balance in order for our heart to function properly, correct? And what ions are needed for our pacemaker cells to work properly? Yeah, calcium, definitely. And sodium and potassium. Proper balance. For proper heart rate and contractility, because a proper heart rate is a depolarization, repolarization event, correct? And if we have any imbalance of those ions needed for our pacemaker cells to function properly, as well as our heart muscle cells to function properly, because remember, our heart muscle cells, they have that plateau to prevent tetany and to allow for proper filling of the heart itself. So those are the three main ions that are really important for proper cardiac function. For function also of nervous system too, correct? Because if you didn't have proper calcium ion balance in the extracellular environment, when our action potential got to the axonal terminal, would you be able to release neurotransmitter? No. So those are actually, you are already learning about what, but it's the emphasis is a little bit more now on what causes the plateau phase. And so you're learning more about that. Let's go into vessels and circulation. Indeed, this is going to be on the upcoming exam, which is at the end of next week. Next week there is no lab, but we do have an exam, so it kind of makes it a little bit nice. You get a little bit more time to study for your exam. So vessels and circulation, chapter 20, structure and function. We have three main types of vessels. We have arteries, we have capillaries, and we have veins. And they're all based on a similar construction, but we will vary the construction layering based upon the function of these vessels. We have three layers or tunics that we need to realize are part of every artery and every vein, not necessarily of capillaries. And our picture shows us that there is a very distinct difference between an artery and a vein. First off, take a look at our cartoon here. Which vessel has a larger lumen? Veins do. Which vessel looks more muscular? Arteries do. And so that is something to realize. Arteries are very muscular. It isn't that veins don't have muscles, because they do, but when you compare the muscular layer of a vein to that of an artery, big difference. The other thing is that when you take a look at the outer aspect of a vein, it has more of a connective tissue looking component to it, and that's going to be called the tunica externa. And so veins have a larger tunica externa than arteries do. Because an artery is more muscular and a vein is less muscular, I call one is muscular and the other is flabby. You guys understand why I call it flabby? Because it doesn't have a lot of muscle layers to it. And when you take a look at the lumen size, one of them is more easily collapsed than the other. And which one is more easily collapsed? The vein. And so whenever you do see an artery and vein on cross-section on the slide, it's easy to figure out which one is an artery and which one is a vein, because the arteries have a more patent or open lumen and the veins have a more collapsed appearance to their lumen. And that's actually what you guys found when you were actually dissecting the hearts. The arteries were easier to pop open, and the veins, you had to make them open because they wouldn't open naturally on their own. Let's take a look at the notes here about the various tunics. So we have tunica intima, tunica media, and tunica externa. So tunica intima is also found in the literature as tunica interna. Intimate means you're close, right? Tunica intima means I'm close to the inside where the blood is. So, and interna is a proper term for that. Tunica intima is the same throughout the entire vascular tree. It is simple squamous epithelium that we call endothelium. So whenever you hear the term endothelium, you know you are in a blood vessel. You may not know what kind of blood vessel, but you know you are in a blood vessel because nothing else has that term, endothelium. And it is, oh dear, and it is continuous with the endocardium. Because remember, the endocardium was also simple squamous epithelium, so they are the same. And so this is important because it provides a smooth, friction-free surface for blood flow. We're going from the inside out, and our next layer is tunica media, circular smooth muscle, and it is innervated, and it is innervated by the sympathetic branch of the autonomic nervous system. And because of that, because the amount of sympathetic output, we will either be able to vasodilate or vasoconstrict. Do you remember when we talked about the ANS in the past, how much sympathetic output causes dilation versus constriction? Do you guys remember? Which one is more? More output is vasoconstriction. Yeah, more output, more norepinephrine, which is the neurotransmitter that's going to be released. The more norepinephrine, it's going to cause vasoconstriction. Vasodilation. Control of blood vessel diameter is totally sympathetic only. So therefore, if you are going to vasodilate or vasoconstrict, it's the amount of sympathetic output that will affect whether we have a skinny lumen or a fat lumen. A skinny lumen is about vasoconstriction, correct? And vasodilation brings about a fat lumen. And so when you have increased sympathetic output, you have vasoconstriction. When you have decreased sympathetic output, you have vasodilation. The tunica media is indeed thickest in arteries. Remember, veins still have this, but when you compare the two, arteries have the thickest layer of tunica media hands down. The tunica externa is also referred to as adventitia. So it's not serosa, because remember serosa is that kind of simple squamous epithelial lining that kind of is like the saran wrap that keeps things pegged down. Our tunica externa is truly adventitia. It's a collection of CT. And our notes do say it's the outermost CT layer. It structurally supports the wall. It is mostly areolar. So remember, that's loose CT, anchors the blood vessels to the surrounding tissue. And is thickest in veins. And maybe you want to say, hey, wait a minute, that doesn't make any sense. What about all those people who have veins that roll? When somebody tries to draw their blood and they stick their needle in you and it goes, whoop, that's not my vein, that hurts, you know? What that's telling you is typically, already I can ask you, how old is this person? Definitely older. And what do you know about everything as you get older? You just don't seem to have as much as you did when you were younger. So indeed, vessel rolling, or when you're trying to do a venipuncture to actually draw blood from a vein in an older person, is a little bit not as, it rolls more than it stays in place. And that is because that tunica externa is starting to deteriorate as we age. Lovely. I tell you all the reasons not to age. And so what are you guys going to do? Age. The alternative is not too fun to think about. Yeah. Life is, as you get older, life does get more interesting because you care a lot less about what others think and say and do, which frees you up. You become a child again, because when you're a child, are you caring about what others think, say, and do? Unless you're obviously a teenager. Yeah. Teenagers care about everything that they shouldn't care about. Yeah. So those of you that have had teenagers can laugh over that. Those of you that had a tumultuous teenager life may not be laughing at it. We all have our own experiences. So right here in this picture, right off the bat, you can easily tell which is an artery and which is a vein. Okay, so obviously A for artery and obviously V for vein here. And the little red dots inside them, obviously blood. So. Arterial system. Arteries transport blood away from the heart. And we have a couple of categories of arteries we want to learn about. We have the first big players, the elastic arteries. And then we're going to talk for a moment about muscular arteries. And then we'll talk about just a little bit about arterioles, which are the smallest of our arteries. Okay, elastic arteries. They do have very thick walls. They have the largest diameter, in other words, also the largest lumen in them. And they are relatively close to the heart. We call them conducting arteries because they are responsible for conducting blood from the heart to the next level of arteries, which are our muscular arteries, which will control blood delivery to the organs for which they are actually next to. What's important about these conducting arteries, they have a very high proportion of elastic CT throughout all of their media, tunica media, as well as externa. They even have a lot of CT in their tunica intima, but I want you to understand it's media and externa, because those are the larger areas of a vessel, the arteries themselves. So we have these muscles and we have all this elastic tissue that's actually woven in with the muscle tissue as well as the adventitia of these blood vessels. And elastic CT is good for what reason? You can stretch it, but what's even more important, it recoils. That's right. And so this is what's in our aorta. And so when we get a big boosh, I like to use, for some reason I like boosh versus bolus of blood. When you get a big boosh of blood out of the ventricle into the aorta, when it is suddenly filling up, it distends, yes? And then when the heart stops contracting, the ventricle stops contracting, you know that the blood wants to fall back into the heart, but it can't because we have those lovely semilunar valves. And so what happens is, as that blood is falling back to the heart, though, we're actually recoiling and sending blood away. Can you guys follow that process? So big boosh of blood into the aorta and then recoil. Well, if you're going to recoil, you're pushing the blood someplace, right? You're not pushing it back into the heart because we just said that door closed on you. So whoosh and boosh. So we get a nice recoil, and that's what helps us to have a continuous flow of blood in our vascular tree. Because there's blood everywhere in the vascular tree, and we're pushing it always along. We get a big one, and then we get a slower push. You guys follow that? The big push is the big bolus, and then the slower push is the recoil that actually occurs. So that's why they're called conducting arteries. They have distensibility and recoil. This allows pressure to remain actually relatively constant in these vessels. And I said relatively, you know. So what are our elastic arteries, or the conducting arteries? Well, our aorta is obviously one. Wouldn't you imagine the pulmonary trunk would be kind of that way too? Our common carotid is that way. Our subclavian and our common iliacs. The aorta is more than just the aorta and the arch. It's all the way down in the thoracic aorta and the abdominal aorta. Do you guys know yet what the first branch of the aorta, when the aorta terminates, is called? Common iliacs. So those are all elastic conducting arteries. They are bringing blood, a volume of blood, to the muscular arteries. And indeed, these guys are medium size, and they will have more smooth muscle in their tunica media than elastic fibers. So they'll have some elastic fibers, but when you compare them to our elastic or conducting arteries, nowhere's near the concentration. So lots of smooth muscle, and we call them distributing arteries because they control the blood flow to the actual organs. So the aorta and all the vessels that I mentioned earlier is kind of like the plumbing to the various rooms of the house. And now we're getting to the rooms, and now we want to control the amount of blood flow to those various rooms. So always relatively close to the organs they serve. So what about renal arteries? Will they be conducting or muscular arteries? Absolutely, they are muscular arteries. Now, after we get to the level of muscular arteries, we will give rise to the next layer, which are arterioles. So let's go into arterioles. So we don't get arterioles from our elastic arteries. We get them from our muscular arteries. They are the smallest of our arteries, and they have the same three tunics. That our larger arteries have, but they are very light in what they actually are composed of. So that muscular layer is just a little muscular layer, and the adventitial layer or tunica externa, very, very, very little layer to them. The interesting thing about arterioles, they are rarely named. So if you come across a blood vessel and they say it's an artery, you know that it's either elastic or it's muscular. So they are going to only name those things which you see. So arterioles, smallest of the arteries, also is to let you know that you can't really see them very easily without some additional magnification. Arterioles are really small, but the smallest of all of our blood vessels are capillaries. And it's just the tunica intima and the basement membrane. And so they're easy to actually break up. They're easy to tear, they're very fragile because there's not a lot of layers associated with them, and the capillaries are a network of vascular structures, typically in an area servicing an organ or other tissues. And so let's take a look at the various capillaries that I would like you to know about. We have continuous capillaries, we have fenestrated capillaries, and we have sinusoidal capillaries. So there's three types of capillaries. Continuous are the most common, and the endothelial cells are joined by tight junctions. And if you remember, that's like snaps on a shirt, a whole bunch of snaps. What's important is they're not designed for large volume transfer of the fluid from the lumen of the capillary to the interstitial spaces. And so that's why we see in our notes intercellular clefts. So in between the little tight junctions or the snaps, we do have a little space. But this is only to allow simple diffusion to occur of small substances. So sodium, potassium, glucose, just simple diffusion to actually occur there. We find continuous capillaries in the capillary beds of our skin, our muscles, our lungs, and our brain. They're not very leaky under ordinary circumstances. You can make anything leakier if you actually increase the pressure that they're undergoing. So they're not very leaky under ordinary circumstances. Unlike the fenestrated capillaries, which have what appear to be pores in them, in the endothelial cells, that are allowing movement of small proteins across from the lumen of the blood vessel to the interstitial spaces that the capillaries are actually embedded in. We find those fenestrated capillaries in areas of high absorption and filtration. And so absorption is from our intestines, correct? And filtration is in our kidneys. So we have fenestrated capillaries in our intestinal walls and the walls of our kidneys in the various capillary beds in those areas. We have a picture down below of the continuous capillary and a picture of the fenestrated capillary. You see the little puck marks of those endothelial cells on that fenestrated capillary in your picture? Those are the little windows, so to speak, and this is going to allow for better diffusion of more substance across that plasma membrane of those cells. So, same basic structure, it's just that the holes are covered by a very thin membrane. So same basic structure as our continuous capillaries, except holes covered by very thin membrane. Makes for an easier diffusion or filtration process for us. Sinusoidal capillaries look like they've been beat up. Take a look at this guy down below here. They look like the capillaries, the lining itself has just all been kind of chewed up. And that's why we call them discontinuous capillaries, because they're wholly, with real big gaps, we can actually move large substances through them from the lumen out into the surrounding tissue. Sinusoidal capillaries are found in your bone marrow, they're found in your liver and your spleen. Because of these gaps in them, we actually have cellular elements leaving the lumen into the surrounding tissues. That's called our cellular elements, formed elements. And it makes a lot of sense that they would be in the bone marrow, because in the bone marrow, that's where erythropoiesis is actually occurring. We do want those things to actually get into the circulatory system so that we can actually have them as part of our blood itself. So capillary beds are everywhere. We'll talk about where they're not for just a moment. Where do we not have rich capillary beds? So when I say rich capillary beds, I'm talking about a lot of these capillary blood vessels making almost like a blush. If you were actually to extract all of the tissue and just highlight the capillaries, it would cause what I would call a vascular blush that would be all throughout there. What tissues would be the exception to having a lot of capillary beds associated with them? Are avascular tissues, such as what kind of connective tissue? Most connective tissue is very vascular. All right, so CAPS, prevalent in all tissues except cartilage, right? Cartilage doesn't have capillary beds running through it, and it's hyaline cartilage, elastic cartilage, and fibrocartilage don't have capillaries in them. What other areas are we not going to have rich capillary beds in? Always associated with poor healing. Joints, that's right. Tendons and ligaments. And what special sense organ won't have a lot of capillary beds as part of its construction? The eye, and what part of the eye more specifically? The sclera, that's right. So you do have a large areas where we don't have these lovely capillary beds, and so we have to get our nutrients via other methods, or we can't get very thick if we don't have as a large nutrient supply from nearby. So precapillary sphincter. So this is talking about sphincters to a capillary bed, okay? Encloses the entrance to a capillary bed. And here we have some right here. So we become an arteriole before we become capillaries. And that's what we actually see here. We see this artery has been given a very, arteriole has been given a very special name, a metarteriole. We'll get a little bit more into that a little later. Okay, so we are an arteriole for sure. And now we're giving rise to a capillary bed, and we have all these precapillary sphincters. And if these precapillary sphincters constrict, what do you know about the blood flow into the bed? It's going to really dramatically drop. And the blood flow is going to go through this central guy called a shunt or thoroughfare channel. And this blood is going to be shunted into the venous system, into a venule, because arterials on the artery side of a capillary bed and the venules on the venous side of a capillary bed. And we would do that. Why would we want to do that? Why would we want to actually deprive a tissue or an organ of blood supply, so to speak? We need it someplace else. For example, if you're in fight-flight mode, do you need a lot of blood going to your kidneys for urine formation? No. So you want that blood to go into your intravascular volume so that it can actually service your muscles that are actually helping you run away from the bear. You know, you need that blood someplace else. You don't need it in these other areas. That won't matter if you don't survive, right? So once you survive, that blood flow will be very important. But in the meantime, in case you don't survive, or to actually help you survive better by giving you more blood to those tissues that are going to demand it at that moment, you are trying to actually do your best to save your life with altering blood flow to various organs. So precapillary sphincter is going to adjust flow or based upon demand. When somebody has a heart attack, what do you notice about them? Very pale. So they had a lot of vasoconstriction going on that decreased blood flow to their skin, but also those precapillary sphincters said, we're going to shunt you back into the intravascular tree or core to have you help us out with whatever is actually going on here. So those precapillary sphincters are very important. The thoroughfare channel is a shunt. So it's designed to bypass the capillary bed that it's actually located in. Let's take a look now at the venous system. Thin walls, when you compare them to arteries, venules are the smallest of our veins and are at the exit of a capillary bed and are companions to arterioles. So if you have an arteriole with a certain, if it happen to have a certain name, you're going to have a venule with a certain name. But remember, arterioles are typically too small to see and therefore to name. But we'll learn that that's a generalization, not an absolute rule. Veins will progressively get larger. Venules will progressively get larger until they become veins. And our notes state here, veins are thin, but their lumen is indeed larger than arteries. And veins are unique in that they contain a structure called valves. And we've seen valves before. Valves are there to ensure one-way flow, right? Isn't that what we have in our heart? We have the AV valves and semilunar valves to ensure one-way flow. Also, our veins have valves to ensure one-way flow. If your walls are flabby, are you designed to actually handle high pressures? No. So remember, the muscular vessels are designed to handle high intraluminal pressures. Veins are flabby. They're not designed to handle high intraluminal pressures. And this valvular system that veins have are actually designed to enhance venous return. Because our system is a low pressure system. Let's see, what else do I want here? Tunica media, a little smooth muscle. Tunica externa, that's the heaviest in our construction of our veins. The other thing I want you to realize about the venous system it is actually can be likened to our blood reservoir. We have at least 55% of blood volume is in our venous system. So more blood is in the venous system than it is in the arterial system. And that's nice because as we go along, we're going to learn we actually have more veins than we do arteries. And what you see externally on your body when you're looking at your blood vessels are what? Veins. And so one of the things that's important to realize internally when you find an artery with a certain name like a brachial artery, guess what's right next to it? A brachial vein. And so we'll have a vein associated with the artery, but on the outside of us, we actually still have a lot of veins that have no arteries actually associated with them. So we have a lot of superficial veins, and these are low flow systems that are actually trying to slowly bring blood back to the heart, whereas the ones that are deeper inside will bring back blood a little easier, and we'll actually go through that too. Well, we are coming up to the topic of vascular anastomosis. And anastomosis is bringing together. Okay. And this coming together will provide us more than one pathway through or to or from an area. It depends upon whether you're an artery or a vein. So coming together and creating different ways to actually get through an area. We have arterial vascular anastomosis, and what will happen is we have two main arteries that supply blood to our hand. Do you guys know what the two main arteries are that supply blood to your hand? Radial artery and the ulnar artery. The brachial artery is in the brachial area of your body, and it bifurcates or branches into a radial and ulnar. So that's actually a collateral. We actually have a radial artery and an ulnar artery going to our hand, and you want to know what's really fascinating about that. It goes to our hand, and it creates two arches. So these two blood vessels, which are in two separate areas after they branch off of the brachial, are going to go down your forearm, associated with those bones, going to go into the palm of your hand, and going to create a superficial vascular arch and a deep vascular arch. So what that means is that those arteries are coming together and creating a continuous loop. Are you guys following me with that? That's an example of a collateral. What's also even more fascinating because of this system, this collateral system, if you needed to have a bypass, if you needed to have a blood vessel graft, do you guys know where they take blood vessel grafts from? The most common one is from the vein because we have so many more veins than we do arteries. But if for some reason somebody's great saphenous vein wasn't satisfactory for harvesting, because that's what they call it, they harvest. They take from, because you have so many others that will actually handle the return, they will actually take the radial artery out of your forearm. And they will take that radial artery and they'll tie off both ends, and they'll take it out and they will use it as a bridge between the blocked areas on your heart. You can do that, can't you, with what I just explained to you? Because that arch in our hand was fed by two blood vessels. And so one of them is actually considered superfluous, which means you don't need it. But it's always nice to have two instead of one routes, to an area or away from an area. So the arterial system, we typically always have two routes into an area. And we call those guys, we'll call them collaterals. And this is really great in case one becomes clogged, but it typically doesn't happen in the arterial system. Let's move down to the venous system before we go to the arterial venous one. The venous system, we have a very extensive return system, and it's very rare to block complete return because we have so many ways back. So in our legs, for example, our thighs and our legs, we have that femoral artery taking blood out to our foot, right? And we have the femoral vein bringing blood back from our lower extremity into our body. Well, on the outside, what we were just talking about just a moment ago is a superficial vein called the great saphenous vein. And it starts at your foot, runs in front of your medial malleolus, and then goes up to your knee, runs a little bit behind the knee, and then comes back up and then plugs right on into your femoral vein. In addition to that, femoral great saphenous vein, if you were to actually follow the veins all the way onto the foot, you'd actually find that all of a sudden there's another vein on the lateral side of the foot. And this lateral vein goes up the back of your leg and actually empties into what's called the popliteal vein. So already there you have a venous arch between those two ways. And that doesn't even include the ones that are actually deeper. So we have a whole bunch of extra veins in our system. And that's why our notes say very extensive return system, rare to completely block this system because there's so many alternate paths to actually get blood back to the heart. Because there's so many, if you find a vein in an area and you don't know what to call it, and it's right next to another vein that you probably call the, well, let's say the brachial vein, you can call it an accessory. There are so many of these all over your body. So you say, here's another vessel. I don't know what to call it. It's not in my book. And I say, well, what would you call it if you didn't have your book? I'd call it a brachial vein. Well, you just identified this one as a brachial vein. Well, then I'd call it an accessory brachial vein. And that's exactly what they're called. Arteriovenous anastomoses, well, this is the thoroughfare channels that we were actually talking about between the arterial side and the venual side. So what's important about an arteriovenous anastomosis is that we are not sending blood into the capillary bed. We are shunting the blood from an arterial side to the venous side so that we can improve our venous return, so we can put more blood out to the important organs that are actually demanding it at that time. People on dialysis will get actual true arterial venous shunts in their arm or forearm, and whenever it's there, you can't take a blood pressure on that side, you can't draw blood from that side or anything like that unless they're undergoing dialysis, and you put your hand on it and it literally hums or vibrates. The pressure is so high, and you can feel it in the venous system. Let's take a little bit of a look at the physiology of circulation, and we've got some definitions to start off with. Blood flow, the volume of blood flowing through any area. This is also synonymous with the term perfusion. Have you guys heard of the term perfusion before now? Okay, so that's blood flow in area. Poor perfusion means poor blood flow. Good perfusion means you look good, nice and pink, and the blood flow is really good. So perfusion and blood flow are synonymous. Blood pressure is the force exerted against the inner vessel walls, and we represent that as millimeters of mercury. And what do we typically measure the blood pressure in? Arteries or veins? Arteries. And that's because they are designed for high pressure systems. On veins, that's a low pressure system. And so whenever we do check blood pressure, we are checking the blood pressure typically of an artery. Peripheral resistance. Peripheral is away, and resistance means, as far as blood flow goes, we're trying to slow down or stop blood flow. So peripheral resistance is, as our notes state here, the opposition to flow. We're trying to slow it down or not enhance blood flow to that area. Now, why would we ever do that? Well, there's a lot of different reasons, but let's go into actually what contributes to this slowing down of blood flow in an area. Well, viscosity or thickness of the blood will absolutely increase peripheral resistance. Increased viscosity means we will get an increase in peripheral resistance. Viscosity is thickness, correct? And so the thicker the fluid is, the slower it will flow. Viscosity issues don't really happen to us unless we have hydration issues, correct? So if we're dehydrated, we know that our viscosity will be actually increased because our blood will be thicker, but that's not something we have too much in our society, yes, unless we're out on the boat on a hot day drinking a lot of beer. But that affects our hydration level by causing us kidneys to actually pee out more urine because of the alcohol that's actually in them. Yeah, diabetics, the reason they have such a high viscosity is typically they're full of sugar. So.
Is this the creamy blood that you were talking about?
Creamy blood is actually full of lipids and cholesterol, triglycerides and stuff along that line. But yes, that also, all these other factors are floating around in their bloodstream, making their blood actually thicker than it should be.
And would heat or coldness, like they say our blood thickens or thins in the summertime during winter, is that true?
We get more vasoconstriction than anything, vasodilation, which will obviously impact vessel diameter, which will impact flow of blood. Because we're going to get to that in just a second. So vessel length. Well, if the vessel is long versus short, which one is going to have a slower blood flow when you get to the other end? The long one. So vessel length, the longer the vessel, the increase in peripheral resistance. So remember, slowage down of blood flow is increasing peripheral resistance. So increased vessel length causes an increase in PR, peripheral resistance. I'm going to make an abbreviation for right now. The reason this happens, you guys realize, is a friction-related phenomenon, correct? As the longer the vessel is, that means more friction our blood will encounter, and friction will slow you down. So that has the main factor to do with that. Now, vessel diameter is what we actually can control, which will affect our blood flow and therefore via peripheral resistance. And so what we know is a smaller diameter means that we will have an increase in peripheral resistance. One of the things that is important to realize that as we follow a vessel on down and that vessel constricts in an area and slows down blood flow to that area by decreasing the diameter, what happens to the pressure, what I call upstream? That pressure is going to start to go up, correct? And so these are other factors that you have to realize, not just in the area that you're talking about, but what fed into that. If we have a constriction, that means upstream we're filling up and we're increasing the pressure in those areas. Which now brings us to blood pressure. Systemic blood pressure. We have a couple of terms associated with systemic blood pressure, systolic BP and diastolic BP. And indeed, they are named for what is the ventricles are doing. So you get a systolic BP when the ventricles go into systole and have that big bush or bolus of blood into the arterial system. And then diastolic BP is during the diastole, and we just talked about how important it is to actually have elastic arteries because we have distension and then we have recoil. And so we will continue to have blood flow during diastole because of this lovely recoil phenomenon of these conducting or elastic blood vessels. What do you guys consider the average systolic blood pressure? Yeah, about 120? Yeah, they keep dropping it on us all the time. Well, that's why we want to just talk about in this class what we're going to call normal systolic blood pressure. We're going to call it 120. So for right now, for us, it's 120. The actual real ideal for an adult, we have difficulty obtaining because of our lifestyle, and that's going to be about 90 to 100 for an ideal for an adult. Now, nobody should feel bad that they aren't around 90 to 100 for their systolic blood pressure. They should understand that 120 for our society is pretty darn good. And as I stated, this is all a lifestyle issue. If you go to the quote, third world countries, there's another term for third world now. What is it called? Economically challenged or something like that. Yeah, they have another, I know, you can never be politically correct enough these days. Okay. But you know, when somebody corrects you, then you, thank you for correcting me. I forgot the name because I'm old. And I have this other name that's been bored into my head since childhood, you know. So third world countries, you know, they don't have a lot of fast food. They don't have a lot of salt. They don't have a lot of fried foods. They're eating a lot of high fiber foods, and their blood pressures are closer to what I say that we actually should be at. So it is truly a lifestyle factor. So 120 millimeters of mercury. This is responsible for moving blood into the arterial system. Your diastolic blood pressure is during diastole, and we know our semilunars are closed at this time. And it is, we're going to go ahead and say this is an average diastolic BP is going to be approximately 80 millimeters of mercury. And this is the average blood flow that is still occurring due to the residual pressure that the recoil that we see in our aorta. So, pulse pressure. You know, you think about that when you feel somebody's pulse. It's a fluid wave. And so when you put your fingers on your radial artery, trying to feel the pulse there, the part that you don't feel is the diastole, correct? So there is volume of fluid in that vessel, that's diastole, and what you feel is the systolic, what I call the systolic boost, the systolic extra volume that's actually flowing in there. So pulse pressure is systolic pressure, 120, minus diastolic pressure, 80, and it is typically around 40. We know blood flow is pulsatile, and it doesn't mean that it goes flow not, flow not, flow not. It goes flow, flow. So big bolus and a little bit, just like a wave. So blood flow is pulsatile. So fingers on, you feel nothing, that's diastole. You feel something, that's the systolic wave that's actually flowing through. So pulse pressure. Mean arterial pressure is a number that is always kind of known for somebody that's in the CCU or ICU when they're having compromise to their vascular system. So they always are trying to monitor this because mean arterial pressure is kind of what I call the speed limit average. So it's the speed of blood flowing through a person's body, and the lower it is, it's synonymous with poor perfusion. The more normal it is, and so we're going to talk about what is normal, that means good perfusion is actually going through the system. So mean arterial pressure is kind of a blood flow story for the entire system. It is diastole, which is 80, and we have it down here, but I still write, plus 1/3 the pulse pressure, which is 1/3 of 40, which ends up being around 93 millimeters of mercury. I hope you realize blood flow is going to be fastest, closest to the heart, and slowest the further away we get from the heart, right? So blood flow slows the further away we get. This is important because when we take blood pressures, are we taking blood pressures at the aorta? No, we aren't taking blood pressures at the aorta. We are taking blood pressures at the brachial artery. And so we've the aorta, the arch, the subclavian, and then the axillary, and then the brachial artery. So we've traveled a little bit of a distance from the heart. But because we know the further away we get, the slower the blood flow is going to be going. But it's still going to be traveling at sufficient speed to actually cause perfusion, good perfusion. And so when you check somebody's blood pressure, the reason we check blood pressure is for a couple of reasonable things. One is perfusion, correct? Because if they have a normal blood pressure, we know all of their organs and tissue systems are actually getting adequate blood flow or perfusion. If they have a low blood pressure, like 80/40, what do you know about perfusion of the tissues? It's very poor. It's being compromised. And when somebody has high blood pressure, that high blood pressure is only in that vessel. It's through the entire vascular tree. And who are the ones that are most susceptible to being disrupted from a high blood pressure? The ones that have the thinnest layers, right? Who has the absolute thinnest layer? Capillaries. So capillaries have the thinnest layers, and so if you have high blood pressure, you are having that pressure differential all the way down the vascular tree. You guys follow me with that? And when you get to capillaries, they are not constructed to handle high pressures. And that's when we'll get into capillary dynamics about that, but they are like tissue paper. You know, tissue paper, you can't carry around a bowling ball in a tissue paper, can you? It's just going to go straight through it. So high blood pressure is bad for you because it destroys capillary beds in your end organs, right? And what's a real common organ that is susceptible to high blood pressure? Heart is, but with capillary beds, it's actually your kidneys, right? People, with high blood pressure, it's not just diabetes that will cause you to actually have kidney failure. High blood pressure is going to actually hurt your kidneys in a negative way. And so it does that by destroying the vascular tree. And we're going to learn about kidneys actually are pretty tough, have pretty tough capillaries to try and actually prevent their own destruction. Let's go down a little bit more in our notes. Capillary blood pressure is 35 millimeters at the arterial end of a capillary bed, so going into it, and drops down to around 15 millimeters on the venual side. So we get a pressure drop of 20 millimeters of mercury when we go through a capillary bed. Well, remember, we start off at 120 for systolic, and then we get down to the capillary beds, and we're down to 35 millimeters of mercury. Part of that is easy to figure out because haven't we traveled a long distance? And isn't that going to cause, quote, peripheral resistance the further away we travel? So this peripheral resistance is contributing to the drop, but also what do we know about the diameter of the blood vessels as we get further and further away from the heart? Smaller and smaller and smaller and smaller, which also increases peripheral resistance. The interesting thing, too, when we get to the capillary beds, we no longer have a pulse pressure. We no longer have a fluid wave. It's pretty constant because that length and the narrowness of those blood vessels have caused us to have a nearly smooth, steady flow through those capillaries. When we take a look at the venous return, what's really fascinating because we're on the venual side, we are starting off on the venual side at 15 millimeters of mercury. So the pressure inside a vein, even though there's fluid in there, the pressure inside the vein and these flabby walls is 15 at the venual end, and as we get close to the heart, right here, look, it drops down to 0 millimeters of mercury at our right atrium. So remember, we equate these numbers to blood flow. That's what we're talking about, perfusion and blood flow. So one of the things it tells you about blood flow in the capillary bed is slow, because the lower the number gets, I hope you can appreciate the slower the flow, because remember we talked about resistance is slowing our flow. So we're slowing our flow in the capillary bed, and then we have a really slow, lazy system bringing blood back to the heart. And so how in the heck do we actually get blood back to the heart if we go from 15 to 0 as we go up the stack as far as the pressure that the fluid is exerting on these very flabby walls? Because you guys know the more flabby you are, the less pressure is going to bother you. So how do we get blood, because these guys have big lumens, they're very distensible, we store a lot of blood in them. How do we get the blood back to the heart? That's what we're getting into right now. We have a couple of things that help us get blood back to the heart. One is called the respiratory pump, and it's not really a pump. We just call it pump as a name, so we should put almost like quotation marks around it. When you breathe, what is the organ involved in respiration inside you? The diaphragm. The lungs are just for gas exchange. You guys have to realize the thing that helps to move air in and out of you is the diaphragm. And so you are a closed cavity, correct? The thorax is closed and the abdominal pelvic cavity is closed, and we have the diaphragm in between the two. And so when you breathe in, like little babies do, which way does the diaphragm move when you inhale? It moves down. So what does that do to the volume of the abdominal pelvic cavity? It decreases, it squishes it, right? It's squeezing the abdominal pelvic cavity. Well, we have the IVC down there with a bunch of valves in it. And when you squeeze on something with valves that's designed to only allow blood flow one way, that blood will actually be squirted up to the next valve, up to the next valve, up to the next valve. So that's one thing. The other thing now, let's talk about the thorax. The diaphragm just moved down, so what did happen to the volume of my thoracic cavity? It got larger, and it's a closed space. And if you take a closed space and you increase its volume, the pressure will drop. Can you guys follow me on that? So we have a pressure in a space, and we suddenly make it larger, and so the air molecules concentration to volume got less. So that's kind of like a suction, correct? If you take your finger and put it on a syringe and you have it partially pulled back, the plunger pull back, and you put your finger over the top, the opening, and pull back, won't it try to suck your skin into it? That's what's fascinating about the thorax. When we inhale, we're squeezing the venous blood back and from the abdominal pelvic areas, and we are sucking the blood back to the heart at the same time. And so that zero, it's okay if we're sucking or pulling that blood in. So the respiratory pump is a very important for venous return. You see that all the time with babies, with newborns, right? When they breathe in, their belly bulges, right? And so that is what's actually causing your blood to come back to your heart right now. As you are sitting here, the reason blood is actually returning to your heart is your respiratory pump. You're squeezing the abdominal cavity, squirting that venous blood back towards the heart, and you're creating a suction, which is like the finger on the plunger, on the opening to your syringe. You're pulling that blood also back into the heart by that suction mechanism of that cavity. So it's fascinating on how things move around. We'll stop there and do a couple clicker questions. I'll fill this in for you guys a little later.